what we're going to do is we're just going to review the normal minimum data set from yesterday, and then I will show you what the guideline they state for the normal ranges here. And after that, we will look at some pathologies. So everyone's seeing the image at the moment?
Yes, sir.
Thank you. Okay, so before we make a start, regarding the minimum data set, what are your thoughts? Anyone has any question on the minimum data set so far and the content or the question regarding the normal variation that we need to acquire? Okay, um, I'm assuming no then, so that's fine. So what I'm going to do is I'm going to show you guys so can you all see this screen at the moment?
Yes, sir.
Okay, so I know you guys use a different guideline and you use the American guideline, but this is the BSC at the moment. So this is based on the regarding the minimum data set for the normal values. As you can see, all the numbers for the left ventricular dimension, volume, and mass, and they all index to height and weight. And then, so again, for male and female are different. They are graded normal, mild, moderate, and severe. So, and LV function from now, we don't go mild, moderate, severe. So it's either normal, borderline, low normal, impaired, or severely impaired. Okay, so some of the places they still use a mild, moderate, severe. And for the LSIs, again, less than 34 mil. So again, that's index, guys. Okay, so normal, and there is a borderline there, 34 to 38, and then anything above 38 is dilated. So regarding the grading is all has changed in the last few years, but just to make it as simple as possible, because sometimes you're sitting on the gray line, whether it's mild or moderate, moderate to severe, or this kind of thing. So, and then you got all the references for your dimension. So your dimension, you look at your wall thickness for your LV. Again, they are all indexed, and for the mitral annulus as well, and aortic root. So aortic root is very important. So lots of the data show we need to index it to height. So make sure you do that as per your guideline, because this have an effect predominantly on people sometimes when they are small, petite, have a small heart, and then somebody who's quite broad and tall. So one thing I don't get it, because you guys follow the American guideline, and when it comes to BSA, uh, body surface area, the Indian people, I'm assuming, I'm so sorry if I get it wrong, they are more petite compared to the American people. So if you guys follow the American guideline, how does that tally match with the people that you guys scan? So that's a question. Go ask all your doctors. Um, Then we have the RV dimension. So again, we with a minimum data set, as we can see here, what they did, we measured the base, mid, and longitudinal, and the RVOT and the TAPSE and RS prime. RA, like I said yesterday, anything less than 11 is normal. All index. So this image here, so there, so all these tell you roughly what you need to do, what you don't need to do, and all the key measurement that you have to do. And again, with the LV mass, it will be again like eccentric, remodeling, concentric, hypertrophy, and all these things. But that you need to put your height and weight, um, gender, and the dimension of the septum, posterior wall, and the LV dimension during diastole. So again, you will need all these values to be able to work out your LV mass. Okay, so you can use this as a reference again, but like I said, that's not going to match from what you're doing back home because you follow a different guideline. But this gives you the key thing here is all these measurements that we are looking at. Okay, all these measurements, because these are the get yourself into a routine to put this into your practice. uh, Anyone has any question on this? Nope. Okay, so I'm going to go through the minimum data set again just as a refresher for this morning, and then that we will move on to the pathologies. So the pathologies that we will be covering today would be like the AS, MR, regional wall motion abnormalities, and these kind of things. So, and then if you have any question on these type of data, just we can talk about it. Okay. So we will whiz through it, so not to worry. So like again, uh, Planck's long axis view, you optimize, you look, and you do your measurement interventricular septum, dimension, and posterior wall. And then during systole, the dimension, then RVOT, and then your alley. We will come back to that in a sec. And then you look at your aorta, zoom on it, make sure it's opening well. You can see the leaflet, the non-coronary cusp and the right coronary cusp, which is opening nice. And then you measure the LVOT diameter during when the valve is open. Go up a rib cage higher, get your ascending aorta as well, and measure your ascending aorta. Then the next thing, you put the color, just make sure there's no regurgitation, there's no communication around. And again, like I said, I do color on this, and you don't have to, but most of the time of the M mode, you what you're looking here is the opening and the closure of the valve a bit more clearer. So then you focus on your mitral valve. So make sure your box is covering the LA so that when there is regurgitation, you can see how far the regurgitation is going. And also if there's any prolapse or anything like that, you can look at it. You do your M mode across at the tip of the mitral valve, as you can see the mitral valve opening and closing. Okay, and the M mode here, you can measure the dimension as well. But be careful with that M mode because if you foreshorten the heart, cut it a bit, slice it a bit more, let's say instead of sliding right in the middle, you slide it a bit here, then that dimension will be a bit smaller. So just be careful with the M mode with that. We don't do it routinely in practice, but according to the guideline on the BSc, you have to do it for your logbook, so our video case. So, but this measurement is very old school, but we don't routinely do it. So then we look at the RVOT. So your tricuspid valve by tilting your probe up. We look, we put the color, make sure if there's any regurgitation, and the CW, look at for your Doppler profile. Okay. Then we tilt down, look at the pulmonary artery, and so you get your RVOT diameter, then MPA diameter. So you just measure them. Um, Again, these measurements are part of the minimum data set. I won't routinely measure them, but for your BSc logbook video case, you have to do that, okay? Um, it's there. But if you see there is you need to do any QPQS or there's pulmonary stenosis, then you will probably need to do this measurement. So as far you got the image, and then is there if you need to. Color, and then your CW, look at the forward flow, um, make sure you have the right scale. And you guys, you can see how I've optimized my Doppler. It's nicely spaced based on the horizontal speed, and so that way you have a clear definition of the Doppler where you can measure. Okay, so always optimization is good. So then we did the PW and look at the acceleration time. So again, like I said, less than 105 is plus elevated PA pressures, and anything above that's normal. So these assessment is good for pulmonary hypertension, PE patient, and any pulmonary congestion type, like even in MS, because in MS what you're looking at is the LA is getting overload, and then all that is going back into the lungs and then go back into the right heart. So it's a vicious circle basically. So you just need to put all these into account. Sometime, like I know you do lots of focus study, but if you're assessing somebody with pulmonary hypertension, then it's not only the right side of the heart you need to assess, you need to assess the left side of the heart as well. So even severe MR, MS, all these will contribute to pulmonary hypertension because of the volume of load into the LA going back into the lungs. Okay, so then we go short axis. Short axis, if you up basal up to the um, aortic level, where you're going to see your tricuspid aortic valve, RVOT, your PA there, the tricuspid, and this is your interatrial septum there, and your appendage sometimes around here. So you measure your VOT diameter and your color into the aortic valve just to look at any regurg. But like yesterday I touched, if you pan around gently, you can see the ostule or of the coronary arteries. Okay, get in the habit of trying to look for it as well, which is good practice. So color on the right side of the heart, just put your CW there, cursor. Just again look if there's any regurgitation. The reason I tend to do it in different planes is, uh, which is good practice one, and secondly, you may get regurgitation in one view better than the other view. So that's why it's good practice just to try it at least. Mainly if you picked up a bit of MR, whether it's mild or moderate, you're not sure, and then at least you have different plane and where you can measure it. Um, just check for the interatrial septum there, and again for the PA, you can do the same thing. If you haven't had a good image, but like this patient, as you can see, not all patients you're gonna get a good image like that, but if you have, it's brilliant. PW and the CW and everything. Okay, so then we pan down a bit more. We look at your um, cross section up to the mitral valve and then your thickness of the wall. So like yesterday I said, just put the color in first to see if there's any regurgitation. And then for these image, now I'm start going down, uh, papillary muscle, and then these are good places where you can measure the dimension as well of the wall thickness, but just be careful of the trabeculation. So can you see all these bit of trabeculation? So make sure it's measured a bit appropriately. And yeah, so I keep tilting my tail up, looking down the heart, and then that way you can go further down up to the apex. Perfect. So we've done the Planck's long axis, short axis view. So we go around, just look at the apical segment again. Um, so apical, make sure you have all the four chambers and perpendicular this to your probe there, okay, your septum. So again, that is could be is very smidge movement of the probe. So once you locate your location, it's just a tail that you need to move, not the whole probe, okay? And it's just very small movements. So, and then I'll optimize a bit, focus on the LV, like put the color on the Doppler there, mitral valve, CW, continuous wave there, and pulse wave, and then do your measurement as normal. So these measurement is very important for the diastolic function. Okay, so mainly if you're assessing your patient for diastology, so every patient you need to assess for diastology. So again, if you're not doing these measurements, so try to put this into your practice on a daily basis, because without this you won't be able to assess the diastology. Okay, so sometime if we have diastolic dysfunction, you can pick these up nice and early, like mainly for patient with heart failure or early sign of heart failure, rather than systolic heart failure. Okay, so that's a pulmonary vein. Okay, so then we look at the five chamber view and focus on the aortic level there. So again, try to move your probe the end bit, not the whole, and so that you align your heart properly with the AV perpendicular to the probe. Okay, that's when you put your cursor on it, then you're nice and perpendicular, which you're gonna catch the opening of the valve nicely. You will get a good waveform. Okay, so mainly for patients with AS, sometimes you do struggle to get a good peak velocity. That's because we are not aligned correctly. So if you can get this practice a bit more on that, that will give you a bit more uh, better reading. So that's my CW and LVOT PW. Again, I tend to put the color across just to see if there's any communication, but a normal heart is fine. But the patient who has MI or pulmonary hypertension and this kind of thing, you want to do that routinely, because just in case there is some sort of communication ruptured muscle. So uh, just adjust your NICUS baseline there when you look at low flow. So now I'm looking at the modified view of the RV, and as you can see the whole of the free wall there. So again, do the routine measurement, baseline, mid, and longitude length, and the fractional area change during diastole, and then systole. It will give you the percentage. Anything above 30 is normal. Okay. Your RA area, again, we make sure to zoom on it and then just measure it. So then, as we're still in the right side of the heart, so just try to finish a few more measurements, do your CW, and then look for the Doppler profile. Like again here, you can see it's a bit more fade. I can see it's up here, but it is a bit incomplete, so I won't bother measure that. I look at it visually is trivial or functional, so I'm not too worried about it. But I still measure, say that into my report, okay? And the TAPSI and RVS prime there. So then we finish in the RV, we come back into our LV side. Okay, LV side. So you focus, make sure you optimize your so that you can see only the RV. So that's when you're assessing the RV, the LV. Sorry, you don't need the RV, you don't need the A train and everything. So by doing this, you optimize, you have a better resolution, you will see all your wall properly, clearly. So then you can really assess it. So again here in so infraseptal wall, that's all your apical segment. So anterolateral wall there, okay? So that's your two chamber view. Two chamber view, you're looking again, make sure you got your apical, everything into your width sector width there. So your inferior wall here, and that's your anterior wall, okay? And then another, just put your color, just make sure there's no MR and everything. So again, like now I've optimized my image. So I'm looking at my original wall motion abnormalities, and these are the images that I will use for my Simpson as well. Okay, inferior wall, anterior wall. So then you look at your apical pre-chamber view from this infralateral wall or posterior wall, um, inferior anteroseptal wall, and that's your apical segment there. So again, from this view, you optimize it to get this, but you will assess your aortic valve there as well your mitral valve. Okay, so color on the aortic so that you see any regurg, and then in your mitral valve as well, do you look for if there's any regurg? Okay, so optimizing your LV cavity in the pre-chamber view. So these three images, 4, 2, and 3, I will use them for my GLS as well. So look at the arch, you measure the aortic arch there as well, and put the color, and you can do your CW and PW there as well. Okay, then you go your subcostal, and subcostal, that's your probe there, that's your liver, RV, LV, and your RA and LA. Okay, so here just look for any, put your color on again, uh, look for any communication across or TR or MR, and then sorry, okay, so that's sorted. And look for your IVC. So IVC, just make sure once you get it, it's nice and open. Get your patient to sharp sniff through their nose, and then you see the collapse. So it's greater 50%. Great. Okay. So Simpsons, like I said, diastole we measure, systole in apical four-chamber view, and then two-chamber view diastole and systole give us all our measurement there. All right. And for the LA volume as well, apical four-chamber view and two-chamber view. You use that, and then it give you your index. So like I said, 34 to anything below 34 is normal, 34 to 38 is borderline, and then anything above 38 is dilated. So the GLS, like I said, we use the three uh, apical four-chamber view of the LV, apical three-chamber view of the LV, and apical two-chamber view of the LV. Okay, so make sure depending which machine you're using, and just AFI in GE machine. I don't know what other machine they have, what option, but once you click on the, let's say, apical four-chamber view, and then you click on the measure AFI, and then sometimes it will pick the best free, and then bring work it out, and then you need to adjust it if you need to. So we've done that, and this show you all the all together, but this uh, the chart there. Okay, okay, good. So I think that was just a recap from the normal minimum database that I routinely do. So before we move on to some of the pathologies, any burning question, please? I'm just going to stop sharing the screen for a sec, guys, okay? Meanwhile, gather your thought for your question. And we're going at looking at regional motion abnormalities, okay? So can everyone see the images, please?
Yes, sir.
Perfect.
Yes, sir. You can see the image.
Thank you. Okay, so this patient was admitted with a cardiac arrest and had NMI, had I believe he had a LED block completely. And so we've just going, so this is a study which I did, and we're just going to look at it together. So like I've already said, this is assessment of regional motion abnormalities as well as everything of the minimum data set. Okay, so although this patient had a heart attack, we're looking for the LV function and any regional wall, but we will still look at all the other features as well. So as you can see, I took my first image there, and then I've optimized. So following the optimization, I've measured my interventricular septum, my LV dimension, and my posterior wall. Okay, so as you can see, it's quite thickened a bit according to the measurements. So one of the measurement of the dimension at the end for the systole, that's fine. And then the SOV, like I said earlier. So remember yesterday I was showing some of the images, and now you can see when I put the height and weight, it already indexed it for you on your machine. So if you don't have this in your machine, it should be in one of the settings. So make sure it's on or program on, and then when you do the measurement, you get all your um, height and weight as well. So again, go one space high up, and then you get your aortic ascending measurement. So assessing the color on the aortic valve to look at your any regurgitation and the morphology of the valve. So again, I put the color normally, but then you're looking at your closure of the valve, opening of the valve. Then I assess the mitral valve. So again, with your cursor aligned, look at the opening and the closure of the mitral valve. So tilt down. So bearing in mind this patient, I want to scan in ITU. So lying flat wasn't the best position. But again, just you do as what you can, and yeah. So again, here you can see the tricuspid valve there, and that's that would be your MPA there. Okay, and put the color, and then to see if there's any regurg, it's trivial there. And again, you just measure the forward flow of the PV, acceleration time, and short axis view. Again, sometimes it's very difficult to define the morphology of the valve, whether it is bicuspid or tricuspid, but then by doing so, this is tricuspid. If you look at closely, you can see the right conus cusp, which is very dominant, and then non-conic cusp, and then a very small non-dominant left conic cusp. So again, just look at this thing clearly. Um, yeah, put your color and have a quick look. Again, cross section, you can put the color on as well or not, but you will still have the same pattern of opening and closure of the valve. So just zoom on it just to make sure I can, because that first image I couldn't see the morphology properly, but zooming on it, and then now I can see it a bit better. So just so that you make sure One thing I would say, guys, is you when you report, you write what you see. Okay, don't assume. So if you haven't seen something, just say unable to see the image clearly, or but yeah, like I said, just write what you see. So if you can't see clearly this morphology to pinpoint at it, then say don't. Unable to determine morphology of the tricuspid valve due to suboptimal images, this kind of wording. So tricuspid color and then CW and then just have a look. Okay, so again, just to look at the interarterial septum there. So now we're going to up to our short axis view, mitral level, and then one with the color. So we can see there's smidge of MR there. And so again here, I've put the color around the septum. I know this patient has an MI, so um, just to make sure there's no communication around. And it's a bit of a chunky heart, isn't it? So, and we keep going down apically. So then we have our five chamber view, and here, as we can see, you can see all the four chambers here. And again, we do our focus again in terms of mitral valve assessment. So our CW and your PW, do all your measurement as normal, and your TDI, okay, and that's your pulmonary vein there, systolic, diastolic, and then again, like I said earlier, make sure the septum is aligned with your probe so that when you put your CW, it's nicely aligned, okay? Pop the color, always pop the color, one with the color to make sure there's no regurg significant. And then when you measure your CW is nice and straight, you have a good. So again here, guys, you can see I've just got two um, images there, but the only reason is I've just optimized my paper speed and scale so that I have a good reading Doppler profile. Then it's easier to trace and see clearly. So again, is this small change that you can bring to your practice about optimization will be really helpful, making your life easy. And then the LVOT diameter, okay, LVOT pulse pulse wave. So again here, I've already did the height and weight at the beginning, measure the LVOT, and remember yesterday I mentioned about when you measure your LVOT trace. Now I have my LV stroke volume index as well, so which is perfect. So that does help tell us a bit more about your LV as well function. Okay, so is this is handy measurement for when you do assess AS as well. So we're going to look at the RV side here. Again, RV, we do all our routine one measurement, color, CW to look TAPSE, and then your TDI. So that's all good, normal, baseline, 3.6 is perfect, and your RA, which is normal. So just pop the color just to see if there's any communication across. And then now we will start focusing on our LV side. Same again. So all my study, my scan are, you will see the same pattern and routine so that I don't miss anything. So my main focus is my LV now. Look at the regional wall clearly. So you can see the anterior wall here. The basal is okay. From mid to apical is hyperkinetic. This bit is akinetic, which is not thickening at all. And one of the things that I tend to do is I take my finger, I put it in the middle of the cavity, and then I see whether it's squeezing on either side or not, and this is, or block one side to look whether it's coming in or not. This kind of thing. It's just silly stuff. Things like that does help visualize better. So that's a free chamber view. Again, here we can see the infralateral wall basal coming up, but the whole apical segment is not functioning well. Just the basal anteroseptal is thickening, but the rest is not. Okay. So again, just put the color, uh, aortic and the mitral, and here this is the full two-chamber view. So as you can see here, not the great. I can't see the wall clearly, but good enough for me. And that wall is thickening a bit, but the anterior wall is hyperkinetic, akinetic. So bearing in mind, depending where your patient is, whether it's an outpatient or ITU, depending how well you can see based on body habitus and everything. Okay, so pop your collar, assess your mitral valve, just have a look, and this is a better view of the two-chamber view. Now we can see the anterior wall a bit better, so, and you can see clearly the mid to apical segment, that's all akinetic. Okay, and your inferior wall is coming in as well. Okay, and okay, so now we've already assessed everything. We That's your subcostal view. That's the liver there, and again, the patient was lying flat. Is no way you're gonna get a good image quality. But that's the IVC on inspiration. As you can see, that's collapsed nicely. That's a hepatic vein there. Uh, you can measure it. It's a bit dilated, 2.4, and that's your arch again. In ITU patient, you're not going to see your arch clearly, but if you do, just put the color so that you can have a rough idea, and the CW. Okay, so that's the Simpson. Again, it's very important to do that in if you have if you have good endocardial definition. I would advise you to always do your Simpson uh, rather than visual assessment. Okay, so and 45% EF and your RA, that's your LA, sorry, and then measurements. And on this one, I did the GLS on the RV wall, and as you can see, is still impaired, TAPSE, as well as the uh, global strain, how the muscle is stretching. Okay, so the free wall strain, which is this, and then the GS is overall. Okay, guys. So as you can see, so you if your machine don't have the RV strain, you can cheat, use the free chamber view of the LV measurement just for that. But again, this just to give you a rough idea. Okay. Uh, so that's suppose. So again, so this from what we've assessed so far with the regional wall motion abnormalities, from what we've seen visually from the two-chamber view, um, three-chamber view, and four-chamber view, and as well as our short axis. So now you can see from the GLS, so all the red bit area, which is dark red, is the wall is thickening nicely, but clearly as we've seen visually, you can see here all these area minus 4, 9, 7, 4, 8, 10. So these area are hyperkinetic, and some of them is akinetic. So this confirm nicely. That's what I like. Sometimes when you do look assess for regional motion from what you've seen visually, and this tied it up nicely, confirm everything what you've seen. Okay, and these are the anterior wall. As you can see, these are the places where the wall wasn't thickening well, and you can see they are very low numbers. And same for the anterior wall there, they are all low numbers. Okay, so that was regional motion abnormalities, guys. Um, any question on regional wall? Okay, guys, sorry. So this is AS we're looking at, so assessing the aortic stenosis. Again, you will see my ECG down there, 1, 2, 3 cycle, or in timing cycle you put it. So make sure your ECG is always on. And once I put my probe, this is the first image I always take. And then the next one would be the optimized image. Okay, so optimized image, as you can see, not the and very chunky heart. So this is, you will see that a lot with patient with aortic stenosis, because remember, if there's a very tiny hole that the blood need to go throughout, the heart have to work harder. So even working harder, there's lots of hypertrophy that you get into in the patient. Okay, so as you can see, the interventricular septum is quite thickened and the posterior wall as well. So it's quite concentric hypertrophy. So again, same data set as normal. Although we know this patient has aortic stenosis, we're not just going to assess the aortic stenosis. We will do a minimum data set for it as well. So you will see my routine always, um, index to height and weight, and again you will see the dimension there. So for this, that's where I like to use the color compare one. And so like clearly you see, I know the regurgitation is not that bad. So I've optimized and zoom on it. My color Doppler is just the right size. And you can see the regurgitation is just going up to here. And you can appreciate in both image now with this valve is opening how tiny it is. Okay. So when I do put my color Doppler on my M mode, so that's opening and closing, and this is a regurgitation that's happening. So sometime, like I said to you, not every people does it, uh, but it's I do it on my study, and sometimes this helped me as well to assess the severity of my AR. And you do one without as well, so you can see as well when you do the color, you appreciate how well or how not well the valve is open and with the color profile. So that's something, again, you just get used to. So I've already looked at the aortic valve in that view. So there's nothing much I have to look there from that view. So I focus on my mitral valve. So again, look at the M mode, the color, opening and closure of the valve, and then you tilt, just look at your uh, pulmonary. So that's your forward flow, which is normal, your acceleration time, which is normal, and looking at the tricuspid valve, uh, look like I didn't take any measurement there, that's fine. And so then you go to your short axis view. The short axis view, again, you're looking your heart cross section. So as you can see, the whole of the annular base of the aortic is quite thickened, calcified. So we will look at this a bit more clearer now. Okay. So color compare and look, we can see a bit of the regurgitation coming there and all these calcification and thickening of the aortic valve. So we assess the PV there again and the tricuspid here, a CW to see for any regurg, and that's your PW there. Okay, so now what I've done is I've just zoomed on the aortic valve so that I can you can define me a bit more about the morphology. It's very difficult to say whether this is a bicuspid or tricuspid because I can see here, let's this is a right coronary cusp, very thickened, just the tip is opening a bit, and this is a non-coronary cusp, and maybe this is the uh, left coronary cusp. So because it's so thickened and calcified, it's very difficult sometimes to tell the morphology, to determine the morphology. So I've changed the color a bit just to see, but here we go. Uh, then we go for our short axis view. We keep going a bit lower, look at the mitral level and color as usual. And you keep going down to look at your function epically. So then apical four chamber view, and you, again the first image you bring all your four chambers like LV, and your atrium, and then you focus on the LV. I think same routine now for everything. So CW, PW, and your TAMP-C to assess your diastology, and then that's the pulmonary vein. You can see systolic, diastolic, and now we are going to look at our aortic valve. So apical five-chamber view, and then color. You can see that tiny smidge of AR there, and then again, like you will see, my image is nicely perpendicular to my probe, so that when I this move to look at the so in the other images so far, the MR look a bit mild, so trivial mild, and then like this you can see a bit much better. Again, you just need to use your probe, angulate it a tiny bit up and down so that you can see the best of the MR. Apologies, AR. So in that image, I could see the AR clearly, and then I put my CW to measure my, and according to the pressure half time is mild. Okay, so make sure you optimize, you have a big, long sweep, and then you can measure your AR a bit better. So that's good. In this image, we had dual pathology in terms of AR and AR. So we look at this. So this is your CW across the aortic valve, and you see when you align it correctly, you manage to angulate it properly with the probe and then you have a good measurement. So this is your CW straight. I think I don't like measuring the fluff bit, but the solid area, as you can see, is in 4.4. That indicates uh, severe AS. So I tried into the free chamber view as well. So I have similar. So I never always try only one plane. So just few different planes. That way you are able to confirm what you're seeing, or you can get better gradient in other views. So again, in the free chamber we are 3.4, 4.3, and then the other one it was 4.4, still quite close. So I've used the standalone probe as well. Uh, But normally I use a standard probe on the right sternal edge, get the patient to turn around the right, and I do it that way first to locate it, and then sometime if I don't get anything, then I take the standalone probe. But clearly, we even with a normal probe is already hit around just above 4, so that's a good sign. And then when I use a standalone probe, as you can see, I got 4.45, even better. So it's always good practice to for all your AS patient to use a standalone probe on the right sternal edge, okay? But the good sometimes lots of people go straight with the right standalone. But what I did here, as you can see, I've used my normal probe first to locate it, to see if I get a good view, and then I swap it, use the standalone probe there. So then with that, I have even a better um, result. Good. So here we go. And as usual, you do your LVOT measurement. And again here, like I said, if you already measure your LVOT diameter and your height and weight, then you will get your LV stroke volume index as well, which is there. Okay, guys. So we go assess our right heart now. So we've done systematically, and then the same routine now. I will look at the right heart as normal, and then your LV, although our main focus here was the aortic stenosis. But again, in the free chamber view, guys, here now you can appreciate how broad and that jet is. And subcostal view, that's the liver, and just look again. Sometime you can just still put the color there, see if you can get any better. And then the IVC, as you can see, is collapsing nicely. So yeah, in inspiration, you can see it's collapsing nicely. Good. And then still look at your aortic arch. We know there's a bit of AR there and it's mild, nothing exciting, but again, just measure the dimension of your arch and then this thing. Okay, the TR, there was some other measurement coming at the back because I measured them afterwards. So the RV base and TAPSE and your so the right heart is fine, uh, RA is fine, IVC is okay, and this is on the arch here. The CW is fine. So again, you do your Simpson, you have a better, what is it, 48%, and your volume for your LA 35. And we did the GLS here, which is okay. And then we did the GLS. So in all my AS patient, I tend to do the GLS, okay? So if you have a good LV definition and everything, because although it will give you a good indication of your LV function, because as we know, it is quite chunky because of the AS and increased mass. And again, you can see here is badly impaired longitudinal function as well. Although our EF was 48% roughly, and but this the longitudinal function, how the heart is stretching longitudinally, it tell you is severely impaired as well. Okay, so that's in the presence of severe AS. Good. Okay, so this is the first proper pathology we've looked at and how many measurement we have to take and do. So please tell me, how do you assess your AS?
Yeah.
Hello, Kish sir, Asha here.
Hi.
Uh, s- Sir, I have a doubt. In normal rhythm, it is fine, but in that AF patients and in like irregular rhythm patients, I have a doubt always that after putting a CW to assess it, some waveform in the Doppler will be small and some waveform will be elongated. I don't know which waveform to select and to get the trace for max and mean for AS, and in for AR also, how to get the PHT, like what waveform I should select. I'll always have a doubt in that, like elongated one or a short one like that.
No, so you always go. So when in the presence of AF,
Okay.
you do a cycle, at least 5 cycle.
Yeah.
Okay,
Uh,
3 to 5 cycle, and then you measure all of them, then you get an average.
okay. In irregular rhythm, like CHP Mobits also, like I should do 3 cycles.
So
Uh,
if you can do more than 3 cycles, even better, because you want an average there, because sometimes there will be ectopic beat as well,
okay,
and if there
okay.
is like slow-hearted, like you said, if there's ectopic, you will have the next one a bit bigger than the smaller one, and then when you have complete heart block as well, you will have it quite slow and different pattern. But in these cases, you just do an average of at least 3 to 5.
Okay.
And this
Okay.
same apply for the AR as well. But AR again, look, if it the sometimes measurements doesn't tally with what you see. So if your eye is better seeing it more than it should be, then by all means go with your visual assessment. But the measurement are there to give you an idea, a rough guide. At least if you take at least like a free cycle, then with a free cycle, you get an average of it. Then you can make your mind up whether it's mild, moderate, or severe, or yes.
And the valve morphology, based on the valve morphology, if the valve is sclerosed, we cannot get the correct measurements of aortic stenosis, right, sir? Or is there any way to get it? Like if I have seen the echo detailed echo report that they'll be mentioning AV valve is sclerosed, and the measurement they say it could not be obtained sometimes correctly. It is not accurate, and they say that
Yes, so what you
the
need to bear in
morphology of the
mind,
aortic valve.
yes, so what you need to bear in mind is that's why uh, this come with experience as well, and how well you align your AV with your probe. Okay, so
Okay.
get into the practice of trying to, if your AV is aligned with the top of the probe, can you guys see this on the screen?
Yes.
Okay, so if you have your AV, the way you put the probe in, you align it with the probe at the top, and then there's no way you're not going to get a accurate result. That's why. But that's why I said we always try in different plane. This is apical 4 chamber. We try in 3 chamber, even subcostal and right sternal. The reason I've tried all this, so to be honest with you, if let's say for this case, on my normal apical 5 chamber view, I've already got this severe. Do you think I need to try anymore? You know?
Yeah.
So, but what I've done here is demonstrated in different plane, like 3 chamber view as well. You can get it nicely. Subcostal, you can get it. Right sternal edge here as well. So there is all different places that you can try. At least what you're showing here is you've tried all these different um, places where if you couldn't get, I'm sure one of them will give you some good data. And so don't just try on one plane apical for 5 chamber view, and then if you haven't get it a good line, so yes. And rightly said about if it is heavily calcified, sclerotic, or not opening well. But the why we are not getting it is because we are not aligned properly with the flow. Yeah. So that's why I was saying if you get your probe, so like even for this one, my probe is aligned there. So for even the apical 5 chamber, I made sure I'll try very hard so that my AV is aligned with perpendicular with the probe. So that way, so the more perpendicular you are aligned with it, you will get a good Doppler profile. So again, just
Thank you.
keep practicing.
Thank you. Thank you, sir.
No worries. Any other question?
So here in this case, how do we report like AV morphology according to BSc guidelines, like
Okay.
reporting?
Yes. So we've seen clearly, not clearly, but hang on, buddy. So let's keep looking at this image, okay? And I personally think it's tricuspid. And let's let's look at this. Okay, so here this image. So this is your right coronary cusp, heavily calcified. This is your non-coronary cusp, and the actual left coronary cusp is quite small there. So if you look clearly, now I will say this is heavily calcified aortic tricuspid aortic valve, predominantly the right coronary cusp, which appears heavily restricted. So you saying that the non-coronary cusp appears mobile but restricted. So the tip is moving, as you can see, but the basal of the aortic valve is not. Yeah, so only the tip is moving there, and the left coronary cusp appears fixed. Okay, so that's one how I was said. So heavily calcified tricuspid aortic valve with predominantly the right coronary cusp, which appears fixed, and the non-coronary cusp appears mildly mobile of the tips with a basal fix, and then left coronary cusp appears fixed. So you've defined all three cusps what they are doing in terms of function. And from what you've seen here by describing it, that tally nicely with what you've seen uh, with your severity of the AS as well. So sometime if you go in the long axis view, I don't think we had a good long axis view, to be honest with you. Let's have a look. Oh, did we? So here, so clearly here, now you can see that's opening. So the basal of the actual aortic valve, as you can see, is heavily calcified and is quite fixed from what we've seen cross-sectionally. And then if you see only the tip bit, these are the only one which is moving a bit, okay? And again, you can see if you keep looking at it, you will see that's fairly fixed only, and then the non-coronary costal bit is a bit mobile compared to that one. So in this view, you will see only the um, right coronary cusp and the non-coronary cusp. Sometime, if that was opening a bit better, when the left coronary cusp is fixed and heavily calcified, then you can see it a bit in the middle there, okay? But that's on rare occasion, but I've seen it in some of the images. So yeah, but the only place that you will see the left corner cast would be into your short axis view. That's the best place to look for it. Did I answer your question?
Yes, sir. Thank you.
Okie dokie. Any more question, please?
Yes, sir. This is Srinidhi here.
Hi.
I have a doubt regarding measuring aortic valve area with continuity equation. Like, how do we measure it, and what are the normal and abnormal values?
Okay. So routinely, I don't measure the area, like preliminary area, and so again, that will depend on your height and weight, and also with your guideline that you're following. So depending on the European, the BSc, and then so if you're following the American guideline, they should for their AS, they should be able, they will have it. Like for example, for here, let's it's less than one is severe, so they have severe, and less than 0.8 is very severe. Okay, so let's have a quick look. What did we get here? So as you can see, the AVA here is 0.69, and then with the index is 0.4. So like, just give me a sec. Like for the, okay, so similarly, you will have some sort of guideline for that you're following. So this is our BSc guideline. We have lots of things, and right heart, how to assess about, and okay, the one that I was looking is not in here, but um, if you download the BSc app, which is British Society Echocardiography app, and there it will tell you everything. So for example, I would say, do you have like a guideline one for your society that you use to report? So this is the BSc EchoCal. Okay, so most of our measurements are in there. And to be honest with you, when you go into AS, it will give you everything in your normal and outer range. So for example, in this case, it's a less than 1, like I said earlier, is severe, and less than 0.6 actually is very severe. And if you go by the valve area by body surface area as well, so less than 0.6 is severe. So all these measurements, so that will depend on your height and weight as well as your measurement. But in terms of area tracing the preliminary, sometimes it's very hard and difficult to do so. And depending how where you tracing, where you cutting, how much is open, due to the classification, you don't have an accurate one. So I will go with your CW and PW when you do this measurement and what you're getting there. I will go with that. And mainly index rather than non-index. Is that okay?
Yes, sir. Thank you.
No worries. Any other question on AS? Okay, just a quick recap. So make sure you get it on a few different plane, try it at a few different places rather than just apical 5-chamber view. And you try to get used to use your standalone probe as well on the right sternal edge if you can. Always try it. So let's say, for example, we have this wasn't severe, okay? It was 3.8, 3.7 uh, peak velocity. Then that's the, have I caught it correctly? Have I not? So then to clear this doubt a bit more, then what I will do is, so even though I've tried in different plane, I will try the standalone plane, because that's the most accurate one if you do get it. So by trying that, then if you still get 3.7, 3.8, then it's great. And if you send sometime, you get even better. So at least you know you've tried all these different planes. Then you're sure this is moderate AS, not severe. Okay, so make sure you do all these measurements and measure your LVOT first before you trace your PW of your AV, because that will help you to get the stroke volume as well. Okay, and other things routinely I would say make sure you do your LV EF Simpson and GLS as well, because although okay this echo was 48% EF, although that, but it was impaired, but we look at the GLS was significantly impaired. Okay, so which our eyes sometimes doesn't tell us that. So the measurement given. So there's lots of pathologies because of the AS. So hopefully after they've put a TAVI or aortic valve replacement, that LV function will improve much better. Okay, good. So let's move on to, should we have 10 minutes break actually? Let's have 10 minutes break and then we will look at some different pathologies. Okay, yeah. Okay, see you guys in 10 minutes.
Hello all. Can you hear me?
Yes, sir.
All right. Okay. So if you have any doubts, actually just ask whatever. That's why we are conducting the live trainings. Okay. So otherwise we can give some pre-recorded records. Okay. So if you have any kind of uh, doubts or any comparison, whatever kind. Okay. Don't think like it's too basic or nothing like that. Whatever the questions, just make sure it's correct your own way. Okay.
Will the experience in India they'll be taking over in UK after finishing the course in UK, sir, to get a job?
You should have the appropriate skills anyway. That's why we are doing this class actually. How, because you're already practicing in India, you're gaining the skills from there. So
Yeah.
by this course, we are aiming actually that data sets how it will be. Whatever the normal we seen or whatever the pathology we saw in India, the same thing how it will be considered in the UK. That adaptation you require actually. That's why
Okay.
we aim this class basically.
Okay. Okay.
So that is a gap between. So try to focus on this actually more. How it
Okay.
will be, whatever the ask, you can ask him actually. The Kish, he is very excited to do that. So he will, yeah, he will help you to do that. So yeah, because skill is always acceptable everywhere, but still you should be aware what the normal data set, how it will be, how the pathology cases has been considered in UK. All these kind of things need to be get sorted actually. So yeah, so I hope this will be helpful for you. What do you think actually? This will be getting your answers
Yeah,
or
yeah, I'm getting it. I'm getting it because here I do screening echo, sir. I'll not be doing in a detailed way because
mm-hmm.
actually there are here 24 beds in CCU.
Mm.
So
Okay,
they'll receive the patients from ER. So
yeah,
sometimes they'll make us to go and see echo in ER also. So
okay,
they'll be just asking what is the EF by doing just in a screening
mm-hmm.
way. Like we'll not be
Okay,
doing this global strain and
okay,
GLS. We'll not be doing that, and we don't have that option in this echo also, which is there in our
oh,
CCU.
okay, all right, okay.
So
So because of
so it
your
will.
working in a clinical scenario, I can suggest you something like if you have time, if you have enough time, actually find some additional time to take more reports in the UK standards. So keep
Okay.
the report format with you. Okay, whatever the
Okay.
normal report with you. You keep a printout of the paper and make some template sheets or something with you. I can send you if you want the copy PDF copy. I can send you, so you can
Okay.
directly take the print and keep it. So whenever you going for the screening the patient, measure these
Okay.
measurements as well. Practice this measurement as well. Okay.
Okay.
Practice
Thank
this
you.
methodology as well. So then you write it manually in the sheets and fill it whatever the required scales. So you will get practiced and you will get familiar with that. Okay. So it will be
Okay.
easy for you once you come into UK and practice in the NHS. It will be easy to pick up everything. Okay. It won't be
Yeah. Yeah.
a huge problem for you. So yeah.
I'm ready when you are.
All right.
Thank you.
Okay.
Thank you so much.
No worries. All right. Okay. After the next session, we will continue. All right. Okay. Um, we'll continue with the Kish training. Welcome back, Kish. You can start with the training. Thank you. Thank you for giving me the time.
Okay, cool. So what we're going to do next is we're looking at some different pathologies. So I've already shown you regional motion normal study. What I haven't shown you is the report. So I'm going to show you that now, guys. Okay, and then before we want, so what we'll do the next session is we'll look at the video and then we'll look at the report, video report. Okay, but I will just go through all these other reports which have just been. Um, this give me two tick. So we've looked at a normal study. So I'm going to go through a normal study first. Can you all see the screen now?
Yes, sir.
Okay, so I'm getting good at this computing stuff. All right, so like this is a normal study which I did. That the video that I showed you earlier, guys, and sorry. Um, so the patient is sinus rhythm. So always make sure you document all your height and weight and the BSA, okay? Because you will need this measurement for your index measurements. So indication, always make sure why you're scanning the patient, and that will. So let's say, for example, if the patient get loss of ectopics, ventricular ectopics, and then these are something when you scan your, and then you will look at different pathologies as well, and make sure you put the rhythm, what it is, sinus rhythm, AF or complete heart block or anything like that, and the heart rate and the quality of the image, whether it's good enough or not. Okay, so clearly, like you said, after looking at the LV functions, I'd say normal LV cavity size and wall thickness. Okay, no significant regional wall motion abnormalities. Normal LV systolic function, the Templeton Simpson biplane is 64%. GLS minus 14.5, normal diastolic function. So this is as simple as I can go. So you can, depending on the machine, reporting machine you're using, or software, there may be different drop down or different type of pre-template, already organized. You just double click on it. I don't know which software you use or you free handwrite. So this one was our old system where we had to handwrite everything. So these what I have in my hand. That's what I've seen. That's what I reported. Okay. So RV normal cavity size with and systolic function. I'll just put the dimension of the cavity there and the FAC, good radial and longitudinal contraction. So I always use this word for me. So when I say good radial, so if there is a good radial contraction and the TAPS is going well, squeezing nicely, okay, so then that way you see good radial, good longitudinal contraction visually or not, okay. So sometimes the measurement doesn't tally with what you're seeing, so always go as well if you're not sure. If the measurement say TAPSE is 1.0 and then when you look at visually is good going there, then I won't go with the measurement, I will go with my visual assessment. So yeah, so LA size, normal size, right? So keep it nice and simple. And aortic dimension, just write what it is. And then what I haven't put in this report is the index, but that's
If they are normal, I tend not to worry about it, but if they are abnormal, then I put the index as well. Okay, so mitral valve, so this is a very basic one. So I would say normal leaflet structure, function, and mobility. This is the way it is, but I tend to describe it a bit more. So I'll say normal mitral valve leaflet, opening wells, thin and mobile. Okay, thin and mobile that you're saying is there's no calcification, no thickening, is opening nice and mobile, is closing nicely, and mobility. So you're talking about the structure, it's mentioned about the function, whether opening and closing, and the mobility, whether it's mobile or stiff or restricted. Okay, so uh, then the aortic is tricuspid aortic valve with normal leaflet mobility and function. Again, here I tend to word it a bit differently. Sometimes I would just say tricuspid aortic valve, the good opening of all the cusp or scallops. Okay, so you use this type of and normal forward flow, no significant gradient. And your tricuspid valve again, normal leaflet structure, function, and mobility. And for pulmonary, if you've seen the valve, you comment on it. If you haven't seen the valve, just write unable to see the valve, and can't you can't define the morphology or anything like that. Okay, but then the other thing that I tend to add is because you measure the CW, you know there's no significant gradient or anything. So then I would put normal forward flow on Doppler. PVAT is greater than 100, so there's normal PA pressure. If it is less than 105, then I would say uh, may suggest elevated PA pressure. Okay, so this is how simple it should be, and then you need so all the measurements you put whatever you guys do, and here your conclusion has to be very simple. Okay, so normal LV cavity size and wall thickness, no significant contributory wall motion abnormalities, normal systolic function, EF of 64% with GLS minus 14, and normal diastology. LV cavity is normal, good function, biatrial normal size, and all valves appear to be working well. So again, in my conclusion, I'm not going to describe anything in details because I know everything is normal. Okay, so that the normal, and then we did look at um, the regional wall motion abnormalities. Here you go. So it was a post out of hospital VFRS in Ukraine, and the patient was helicoptered to us, where he had a balloon pump in place, and he already had PCI to LED, and so I was just asked to do an echo just to check for LV function and for regional motion abnormalities. Okay, so again, just put your rhythm, your heart rate, and how well was the images. So for my LV cavity, if you remember when we discussed earlier, it's a normal LV cavity sound with concentric hypertrophy of the LV wall, apical cap, mid to apical cap, so that's including the anterior, anterolateral, and anteroseptal walls are severely hyperkinetic, and GLS significantly reduced, and impaired LV function, and normal diastology. Okay, so and then our RV was normal, good radial and longitudinal contraction, and normal TAPSE, RVS prime, and normal RV systolic function. Biatrial normal size, and then like you say here, put the aortic dimension, which the size and then the index altogether. And the pericardium, I did mention no effusion, it's normal. And then all the valves was working absolutely fine in that patient, if I remember well. So I'm not going to waste my time describing too much in details. So if it is functioning well, normal, 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 it's fine. And the measurements, so I think this patient had an index of body LV mass index of 180. So my conclusion, keep it nice and simple. So dilated aortic root, like we've by index to height, uh, concentric hypertrophy, and then I mentioned about the regional motion abnormalities and my LV function. RV was normal, uh, bilateral normal, and all the balance appears to be functioning normal. Okay, so you can see, even though I was there to assess the regional motion abnormalities and also um, the LV function, but I still did all my minimum data set and then reported on them as well. So what you need to think about is when somebody non-cardiology looking at this report, they look at this report, they read at the conclusion, it makes sense what's going on. Okay, and if they want to know further more details, and then they can look at all the other bits what's been described at the top. Okay, so that's the two, and then the AS one. So let's see how. So again, we knew this patient who already had AS. It was for TAVI clinic before we sent him for a TAVI, and so he was sinus brady and a heart rate of 52, 54, and so again, I've described the LV, moderate concentric hypertrophy of the LV, radial contraction with reduced good radial contraction. So that's sometimes I said the LV could be contracting well radially, but longitudinally there's hardly any. Okay, so I describe that in a way good radial contraction with reduced longitudinal contraction. This is backed up by my visual assessment and also by my GLS. Okay, so low normal LV systolic function, the presence of bradycardia. So again, so I said the LV function is low because in the presence of bradycardia, I know the heart rate is going slow. So in context of the slow heart rate, that's the LV function. Maybe if the heart rate was better, and we could have a better LV function. So it does all depend. This is how you put it down. And then you have your elevated filling pressure by TDI, grade 2 diastolic impairment. So again, I think that's changed now on our guideline. We don't grade them 1, 2, 3. We just say whether they're impaired or not and elevated filling pressure or not. Okay. So RV, we put normal size, normal radial contraction, reduced longitudinal function. Again, that's from my GLS a bit and from what I've seen. Dilated LA by index, normal RA, and dimension of the aorta there. I'll put everything. And now let's go. So the key thing here I want to discuss is the AS. Okay. So myelophic and mitral valve we put opening and trivial MR. So that's fine. So now as you can see the way I'll describe my AS is heavily calcified tricuspid aortic valve with all three cuspid pairs restricted. Okay, because remember when we look at the image, the basal were all very restricted. Only a couple of the tip of the leaflet was opening. So then the peak velocity of 4.5. So here I put the best image I got by the standalone probe. Okay, so make sure you put that whether it's flat view or subcostal or free chamber or whichever the best view you had it from. So max gradient, mean gradient, AVA of 0.7 and DVI is 0.2. Measurement by continuity equation suggests severe aortic stenosis. And then I mentioned about the AR, which was broad, central, and mild plus aortic regurgitation. Pressure half time was 828 milliseconds. But again, here you will see how I would describe my. It's simple. It was broad. It was central. Okay, so at least you describe how the regurgitation is, and then the tricuspid and the pulmonary, and as usual, all the other measurements. So again, with my uh, conclusion, all the others function, but the key one here is severe aortic stenosis with mild plus aortic regurgitation. So now if they want to know a bit more about it, they can go and look above where all the measurements are or whichever side you guys keep your measurement. Okay. Yeah. Uh, so that's how. So any question on this reporting so far? Because I think it was important for me to show you how they report and describe thing here in context with the images. Happy everyone? Okay.
Yes,
So
sir.
next case we're going to look at, what did I say here? Aortic regurgitation. Okay. So I will skip with lots of the minimum dataset images so that we can focus on the main pathologies now, because I think you sick and tired hearing me saying minimum dataset normal. So again, standard images I will take and measure the cavity, and that's the M mode, and then now we can see a bit of the AR. Okay, I focus on it. So and so that's why I like to do M mode with color, because as you can see here, it gave me when the valve is closed and how much regurgitation there is. Yeah, so it's that's why I like to use this as a visual assessment as well. And my LVOT to just assess the other valve as well as usual. So this is my short axis. So this was quite a big patient, I think. Um, and as you can see, the image quality is not great. But so that's a PV max and the PV acceleration time. I'm just going to skip on this, guys. Okay, let's focus on the. Okie dokie. So it's. I'm sorry, guys. Just give me 1 sec. Buka Delta and Chikama Mobi teacher. Like Mama Flipa Boja. Thanks, bye. Sorry. So again here, you can see it's very dilated and it's quite balloon. Let's click on this. We don't need these. So this is my. You will encounter this a lot when you do the mitral valve inflow and your CW, as is you can't see your ENA clearly here because of the AR. Yes. So if we go back, uh, let's see that. So that AR is going right on the anterior leaflet of the mitral valve, and so hence you can't get a good profile there because it's really disturbed by the mitral valve, aortic valve regurgitation as well. So and again, here is very hard to get a good image. Okay, so now we focus on our aortic valve regurgitation, and as you can see, so hence, like now, you can see how I put my collar Doppler up to the apex because it's going all the way up the mitral valve, the aortomitrale continuity, going all the way up to the apical segment of the regurgitation. So which is quite significant. So then here I focus on it a bit more, and there's a bit flow conversion there as well. And here I've just changed my Nyquist baseline. So now, so when you remember when you measure your PISA, always make sure you have the tail segment when you have the head there, okay? Because never measure the PISA if you don't see the regurgitation, because that's not going to give you a true correct value of it. So now you can see the tail regurgitation, and then you can see the head of the PISA there that you will measure. All right, and here you go. It's 0.9, I think, just in the border cusp of severe. So again, like I said, you see the head and then you see the regurgitation there. So make sure you see the tail and of it as well when you measure them. So that's the regurgitation, because it was so broad we couldn't get it proper. Then now just the PISA trace, and then you got the AR regurgitant volume of 101, it's quite large. Okay, and then the pressure half time, which is 192. Again, that's significant. Okay, so the more steeper it is, the more significant it is. And then you do your AV as usual, and yeah. So all the other measurements. So here, guys, you will see I've done the aortic arch, and I've measured the pulse Doppler there, a pulse wave. So this is a flow reversal of the regurgitation. As you can see, 0.4, so 0.2 above is significant, and in this one you can see the flow reversal very significant. Okay, let's see if there's an image of it actually. Okay, here we go. So can you see the color there is very, it's not as usual as you will see, and that by just looking at the color flow Doppler there, that give you an idea about the uh, regurgitation actually. Okay. Okay, so we've done that. I've done it with the CW and the PW as well, but I think I've got the same result. And here again, so remember, if you measured your LVOT diameter at the beginning and then your height and weight in, then you will get your stroke volume index as well. And then I do all the other measurement as well as usual. Okay, so that was AR. Any question on AR? So that's a three chamber view, as you can see how broad is going at the back there. See, but just looking at it, tell you it's severe. But yeah, and then the flow reversal of the arch definitely confirm it. So yes, look, sometimes accident finding in the liver there. I don't know. I can't remember if I mentioned that in my report. We are not trained to do comment on the liver, but I think yeah. We look at the report next. Okay, guys. So did the GLS as well, as you can see, severely impaired. 12. Good. Okay, let's look at the report. What did I say? So severe AR, query systolic function, query mechanism. So I'm not going to describe the other things. So let's go straight into the aorta, aortic dimension. We measure that, and also that's how I've described my aortic valve for the AR. So myelithic and aortic valve, we focal calcification of the right coronary cusp from some of the images acquired. So okay, so I describe what I've seen. In some of the images I've seen, that's what I've said. So severe aortic regurgitation, AR PISA was 0.9, AR EROA 0.8 centimeter square, and regurgitant volume 101. Okay, so again, you go with your we call it, with your guideline how they describe it, and then use that to quantify the regurgitation. and the flow reversal was prominent and holodiastolic flow reversal seen in the descending aorta, which Narti described, and the velocity was 0.4, which was significant, and the pressure half time was 192, which was significant. So again, I got all the measurement there to back me up to quantify what the AR is, the severity of the AR. And my conclusion again here, I'll just be dilated aortic root 4.1 SOV, severe aortic regurgitation, and the rest what it is. So again, the main focus here was the regurgitation and the dilated SOV. Good. Okay. So, any question on that, please? If not, I'm moving to MR. You happy? Okay. Let's move to MR. And so again, I will do everything as routine. And you can see this ECG is like very weird. Look at the P wave there, massive. And optimize, you can see, but from this image here already you can see the LV dimension is quite dilated and sclerotic type of aortic valve. You can see your RVOT there, okay? And then again, you can see the apparatus is just almost not closing properly, is just touching each other at the end of the leaflets. So LV dimension 5.6, that's basal, and we assess as usual. So again, if you've noticed so far with my studies, I have the same routine. I go with the same routine. So that way I don't miss anything. Okay. And so this is my, sorry guys, that's the MR on the box. Just make sure we look at it. So here you can see from this view, it doesn't look that bad, but it's quite broad venoconstrictor there, but we will have a better look in the different views. Again, I'm just going to skip the one. So there's a bit of PR there. So you can see the smile, and I measure it here as well. That's a PR, the N, PR and Vmax there. Okay, so that's a PW. Let's not focus. And then short axis view, as you can see, tricuspid mildly sclerotic there, but all three leaflets opening well. And there we saw that there's two jet coming from the PR, a two focal jet mild. Just going to skip all that, guys. There's no communication into atrial septum, and this is my short axis view. So even though, let's say here, probably, you can see still open a bit, but let's put the color and have a look. As you can see, that's a regurgitation coming through, and you do the rest of it, okay? And now we're going to go to our full chamber view. As you can see, that LV doesn't look happy, does it? It's dilated, volume, and that's quite stretched. That's so yeah, the anterior leaflet. So here we go. So now you can see the jet of the MR going at the back of the alley wall, and then there's a bit of pieces there as well, as you can see. as you can see. So what I've done is I've reduced my Nyquist baseline there, and there we go. So now you can measure your PISA and as well your regurgitant volume there. Okay, so I've tried to pan around a bit because sometimes just one view you can't get it correctly. So just try to tip your tail up and down gently to see if you get the best MR, you know, the most where you can get the most MR. So yeah, and as you can see 0.9, I've measured it. So always, like I said, when you measure your PISA, make sure you see the tail end as well. And that's my CW Doppler, nice and dense and thick. And then I measured it. So again, you will see here what I've done, my paper speed I extended so that I have a better view, and it's only 2, and then I can trace it nicely. And the regurgitant volume there is 39. And here, the pulmonary vein, if you don't do that routinely, here you go, just during, whenever you have severe MR, you can do it, or moderate, and then you can get your hands practice, because now you can see the flow reversal. So this is a systolic, this is the diastolic, and because of the severity of the MR, so now you can see it's gone reverse because of the MR is quite severe. Good. So that was MR. So then we assess all the others as usual, and I don't have to go through that again. I think there was a bit of TR as well. So although my focus here was the MR, but again, we do all the other measurements as well. So this is a 2-chamber view. You can still see the MR there. And then sometime in the apical 4-chamber view, I've already had a better PISA there. So if in this 2-chamber view you have even a better PISA, if you see, by all means measure it there, okay? So you don't have to use it on one image plane. And here also, where you can measure your PISA if you need to, if you see the MR even more from this view. Okay, good. And any question on MR? I don't know about you guys, but if can you all see this liver with the 2 eyes and a mouth and the nose there? Sorry, it's just me being silly, but yeah. So, all right. Any question on MR, please? So look at that GLS, guys. Minus 5.7. That's very severely impaired, isn't it? It's dilated, but the LV is not doing much. So remember, in this case, what was the EF? I remember. Let's have a look. Okay, there we go. So that's one thing always think. So I've done a an EF, and it's suggested 33%. Okay, it's severely impaired already, but I think it's more than that. But bearing in mind the severe MR, okay, so this is not the true uh, reflect of what the LV volume is, because when you think when the heart is squeezing, and then most of the blood is severe, quite a large volume is going out in the LA. So, which means this is not a true. So, although if I got an EF of 33, I would say severely impaired LV systolic function with an attempted EF of 33% in context of severe MR. I will add that to it because when you think about it, when your heart is squeezing, although that's what you're getting, but loss of the blood's gone even further out in the LA, which means this doesn't reflect what we're seeing in the numbers here, which means this LV is even more severely impaired. Okay, so and all the other measurements. So let's look at the report. Oh boy. Where's it go? Yeah, severe amount. Okay, I don't think I have a report for that one, guys. I'm so sorry. But like I said, what I've just explained, the way I've described it is you describe it's hugging the back of the wall, and it's broad, and then you mention about your flow reversal in your pulmonary vein, and you mention your PISA, regurgitant volume. So that's how you look. And also the reason the if we look at the leaflets, if we look at the leaflets here, they're mildly thickened, yes, but it's not it's not heavily calcified. So this is more due to the dilatation of the LV cavity that's causing the apparatus not to close. Hence, we're getting the amount of regurgitation. So you just, by describing all this. Okay, let's close this because that's done. And severe AR, just done that. Let's get rid of it. Have a look at this in a sec. So we've done normal pathology, AS, AR, done. So we have a couple of more videos to show you guys, and then so this one is a amyloid case, amyloidosis, infective endocarditis, and let's have a look together. So again, this is my first view. As you can see, um, that's your heart, and that's pleural effusion there. And then make sure you mention that in your report. And again, now I've optimized to get a better view. From this, you can see how chunky the heart is, and it's not doing much, is it? Again, I will do all my normal minimum data set as standard, and the only different things I will do here is look if there's any LVOT gradient. So I will just whiz through these guys, okay? And your measurement, your MRTL, MR, WTL, and your PV. So here you can see for the first time, I think it's 95, it's less than 105, so which may suggest elevated PA pressures there, okay? And this is your tricuspid aortic valve, and clearly you can see the is focal calcification of the right coronary cusp and the non-coronary cusp, and then the left coronary cusp appears fixed there, doesn't seem to be moving much there. So again, when you describe your aortic tricuspid aortic valve, just put all these things into it as well. So just trivial AR. Okay, look at this. Again, I tend to double measure it for some reason. That's good. And okay, so now we are up our short axis view up to mitral valve. So let's have a look at this, and you can see how chunky the wall there. And I think I did measure it. There you go. The septum inferolateral wall there. If you go a bit further down. Okay, so that's the view, and then we amyloidosis type of patient of heart, you will see biatrial dilatation, very speckly LV cavity, and I believe the BSc recently uh, did a new guideline, especially for assessment of cardiac amyloidosis. So by all means, if you can access the BSc guideline, you'll be able to see them there. Or I can ask Gigi to share this with you, at least to give you an idea. Again, you see, it says we have to do all our minimum data set and some of the measurements that we have to do, and what are we looking at in terms of the wall thicknesses. Okay, so I will get Gigi to share this with you, which is this is came out from the recent guideline. Okay, so let's have a look there. And epidural pericardial effusion around the RA. And okay, I'm not going to spend too much time here. But what we're going to look here is so the AV as normal, the LVOT, and then we just I'm sure I did it just to check if there's any gradient in there. I don't remember if I did it or not. Looking at all the function, but again you can see it's very speckly, and this is a TR. So there we go. This is atrial flutter. Okay, and as you can see the P wave going there, and then you have the QRS and your P wave there. But again, you will see I've measured at least 3 and to give me an average. So yeah. Again here you will see I've done the same because that's a big, medium, small. Give me an average of that. And the PISA on the same, the PISA for the TR, I've done it here. Make sure when you do that you see the tail end and the regurgitant volume. Optimize your scale and your paper speed so that you can have a good, nice definition so that you can trace it nicely. Just have custom view. And the RV, or this is the best place to measure the RV wall. As you can see, there is thickened as well. So that's the IVC there. It's dilated, and that's a FAC and the GLS. So again, the GLS is part of the assessment for amyloidosis as part of our assessment. And also it says relative wall thickness for the LV mass, which done, and make sure the LV stroke volume, we assess that increased ventricular mass, which we have seen, and if there's any pericardial effusion, which we've seen in this image as well, and the valvular thickening, and as we can see, they are quite thickened and calcified, and biatrial dilatation, which is part of the assessment, and the mitral Doppler as well, and the TDI. So again, to assess the cardiac amyloidosis, so all these part of your minimum data set. So by using all these data except the one which is extra is the GLS, and which we've done extra, and then the rest you should be routinely doing all these minimum data set to help you assess your to get a diagnosis basically from your imaging. So that's RV. So here you go. In amyloidosis, what you're going to see is the apical sparing. You will see everything very hyperkinetic or akinetic from basal going up to mid. So mid apical, then the apical segment, there's a bit of functionality there. So these are you will see the apical sparing on the GLS like that. Okay, and you can see it's -4 severely impaired longitudinal function. So in this case, I did the LA strain just to look at how. So we looked at the LA reservoir there, but don't worry about that too much unless this has been included in our diastolic assessment now. So yeah, but there's not lots of study on it, but it is coming up as well. Okay, EF around 20%. Okay, this was amyloidosis, and we touched a bit of the guideline, which is fine. Any question on this at the moment? Nope. Okay, cool. So the next one we are looking at is this is the last one I'm going to show you about some liposarcoma patient which was transferred to us. This was residual left in the LV cavity. So I so this patient used to be followed in a different hospital. So I didn't have all the data there. And for the first time I've scanned this patient in our trust here, and then you look at this and say, whoa, what is it? So yeah. Before we do that, I don't know if I have the report for the amyloidosis. Yeah, I do. Okay, let's go through that report of the amyloidosis actually, and then at least we got this out of the way. So the patient presented, they indicate, oh, it was 95 years old. I don't know whether it's still alive or not. So BNP elevated, so very high sign of heart failure. Atrial fibrillation we've seen in flutter, raised JVP, strep positive, and you murmur. Okay, so that they were all these indication. So for my LV, that's how I would describe it. Small LV cavity sign with severely concentric hypertrophy of the LV wall. Okay, and severely global hyperkinesia of impression with impression of speckle cavity appearance with very supportive of cardiac amyloidosis. And attempted GLS -4% and severely impaired LV function 20 to 30. Unable to assess diastology in the presence of AF in this situation, but clearly that would be raised filling pressure and impaired diastology. So the RV as well, I mean hypertrophy of the RV free wall, we've measured it in the subcostal view, significantly reducing radial and longitudinal function, and GLS attempted, which is reduced again, -7, -9, and TAPSIF 0.6, so which is severely impaired RV systolic function as well. And FAC was 19%, 30 with normal below. So for me to say, as you can see, for me to come to the conclusion it is severely impaired of the systolic function, I've got all these measurements to back me up: my radial contraction, my longitudinal contraction, my GLS, my TAPSE, my FAC. So all this I can confidently write and into my report to say that this RV is severely impaired because of all these measurements. So hence in here, in many countries, people scan and report, but here they rely a lot on our clinical report if you are accredited to a very high standard in terms of BSc, because you're making these diagnoses and then they will base your treatment from what you wrote there. Okay, and mainly non-cardiology team, if some of the cardiology doctors here will review the images for themselves from what you wrote, but at the end of the day, if it is a non-cardiology team, they will rely a lot on your report that you've written, so that to base treatment. So again, here with the LA dilatation. Uh, so here the RA came normal side, but then I quoted by index. Okay, so and then the aortic aorta, how the sizes, and the pericardium. And again, I'll say pericardium moderate effusion, 1 to 2 centimeters that we've seen around the RA, but we didn't see the RA wall collapse or no RV wall collapse or anything like that. We saw the large pleural effusion of the very first image, so I mentioned that. And then, so let's look at the aortic valve again, because that's I was querying whether there was endocarditis there or not. So sclerotic tricuspid aortic valve, we classify fixed left coronary and right coronary. Open valves and non-coronary appears mildly restricted with opening. So with the non-coronary appears thickened and with possible and suspicious of endocarditis based on the clinical presentation. However, no discrete vegetation. Image, I will discuss it with one of the doctor, and suggestive of tear would not change diagnosis. So let's look at it again, because so that's my long axis view, and always when there is some sort of vegetation, there is sometimes presence of regurgitation as well. And here, as you can see, guys, it looked like quite fluffy and flicking at the end. So it was a bit difficult for me to say, because of, but the blood markers was positive for, I don't remember what it was positive for, but yes, strep positive. So this is one of the indication as well for blood culture for endocarditis. So hence, that's the only place which I could think there is something there. And also, let's look at the short axis view as well. So again, from the short axis view, from the non-coronary cusp, which we were thinking is a bit thickened and fluffy there, and it's very difficult to say whether there's something there or not. So hence, I got myself covered just to get one of the doctor to double check it. And so yeah, the more you look at it, you can stare at it all day. Sometimes you won't see anything. So yeah, but that's where that was. And our last image, like I said, we're going to look at, so we've discussed that already. Okay, let's close this. And we will look at the image first, and then, yeah, then we look at the report. So, so this is my first image there. measure as usual. So far I haven't seen anything there, okay, other than this thickened chordae there, papillary. That's my, let's go straight to four chamber view. So these are the routine measurements I'm doing, and not four chamber, let's go short axis. So yeah, so now I'm looking at my mitral valve, and then now you see at the papillary muscle here, you can see it's quite thickened, a bit big, and then while I was cutting even further down, you can see this blob there, and so I didn't know what that was, to be honest, at the end, because I know, so I didn't know whether that was something new or anything, because this patient presented for the first time I'm scanning. I didn't had any previous study for this patient. So yeah, and so yeah, just carry on. What you do, you just put a brave face and then just carry scanning to see if you've seen something horrible in it. But then if you see in the apical fold chamber view, you can see this big chunky muscle there, where it is. Again, it was very, so like now you can see a bit better. So this patient has had some growth there, and which had been resected before, but I didn't have any of these images. So this is just a residual things that's been left there, which has been benign apparently. So yeah. So if you look at our previous image now, sorry, that's something we completely haven't said. So our mitral valve there, it looked quite thick and annulus there, and so it's whether it's opening or not, we don't know, can't see it clearly. But then you can see on the CW, you have a mean gradient of 7, which indicate of mitral stenosis there. So yeah, so do the standard routine tests, everything as normal, the minimum data set as you go along. So now, as you can see, the LV cavity, every now and then you can see these blobs coming up, and you can see in this two-chamber view actually a bit more. Can you see that on your left? So that's all. And again, in the three-chamber view, at some point you can see it there. Here. So yes, but the patient presented well, nothing, you know, no fever, nothing. It's just been fine. No shortness of breath or anything like that. I don't think so. It was a long time ago I saw that patient. Um, so again, when you're not sure, you see something new like that, you try to go back and have a look a bit more into details. So what is it, or can you see in it whether it's attached, whether there's a stalk in it, or whether it's wobbly and all these things. So yeah, so you can see it from the subcostal view as well over there. So you report it as normal, not normal, but I mean you report your normal study as routinely, and then you just add whatever extra you've seen in it. So I did measure it at the end of it, so just to demonstrate what it is. Then short axis view as well. And yes, so let's look at the report, what I wrote there. Okay, so okay, history of well differentiated liposarcoma of LV and mitral valve, debulking of the tumor and mitral valve MVR in 2005. Here you go. So the the reason for the mitral stenosis was because of the presence of had a MVR before, as well as they had the resection developing of the tumor that they had there. So again, I've said highly suspicious of mobile mass measured close to the infrareceptor wall, overall good function, and I didn't uh, measure the diastole in the presence of mitral valve replacement there, repair. Sorry. And so that hence the reason you see the annular quite thick and round because of the annular ring in there. So, and also the LV normal. I'll just comment on these thing and the mitral valve. That's the main thing now. So MVR thick and MV we classify annular and ring. So mitral valve tips opening well with mild plus mitral regurgitation. Thickened papillary muscle, flanks, and long axis and short axis views that we've seen. We measured it. Quite suspicious of mobile mass. Moderate mitral stenosis with a mean gradient of 7 millimeter per mercury. So, and then the rest was routine. So again, your uh, main focus for your conclusion would be that mass for me, and suspicious of what I've seen, and no previous images to compare from Royal Brompton. So that's where the patient has had the last echo and follow up done there, and so I don't know whether this is progressing or not because I don't have any previous images to compare with. So again, it's handy to put all these things into your report because then you covered yourself, you and then the doctor, whoever's reading it, then they know what's going on as well. And I had it reviewed by one of our cardiology consultant here as well. I mentioned about my MVR and everything, that's standard. Good. So, any question on that one, please? Just going to review the report that I've done on mitral valve mass and MVR. So in this case, this was just a focus study to assess mitral valve endocarditis, previous large fungal mass, and new temperature. So we know this patient has had endocarditis. So I just want to do a focus study only on the mitral valve. So that's what I wrote there. So tissue MVR appears well seated, no significant valvular regurgitation, and the gradient. So I did say echo bright structure seen, and moving into the LA chamber, and how that cannot rule out mass. And I did discuss it with the doctor. So we did discuss it with the doctor, and then at the meeting, mobile structure highly suspicious of mass appeared to be attached to the anterior wall leaflet moving to the atrial chamber. So that was the conclusion. I don't know if I have the images, guys. I will show me. I will see if I can see. And then the other report which I've done, I wanted to show you guys was. So again, this is a patient with normal coronary arteries. We presented with chest pain, query Brugada on ECG with troponin negative and query Takotsubo. So when I remember scanning her, so normal LV cavity size with remodeling, good radial contraction, longitudinal attempt and GLS minus 12%, which means reduced, and there was radial normal LV systolic function. But like I said before, if the EF is normal here and then the GLS is abnormal, then it's not a normal function of the LV cavity. So this is a debate that I keep having with doctors and other people, and it is all in context what you're saying. So I'll leave that to the doctors. At the end of the day, we as echocardiographers, physiologists, we get this information, and is there for them to make the final diagnosis. Uh, Here we see the RV cavity, hypertrophy of the mid-cervical free wall, and the GLS was normal. So that's why I was suspecting of, for me personally, I was thinking whether it's ARVC or not. So I think they did send the patient for a cardiac CT MRI just to see if there's any uh, protein phenotype of tissues around the RV cavity. So okay, let's have a look if I have any of these images. I don't think so, guys. But meanwhile, do you have any questions?
So to find a pannus in the chamber, they say pannus a growth, it is there. They say pannus is there, and
Yeah,
they say they say if there is a clot, they say that that region will be hyper like akinetic, and there will not be flow, color flow. They'll put color flow, and they'll see whether the flow is there or not in the particular region where there is a clot. So
yeah.
they find the clot, and I don't know how to find a pannus. And second thing is vegetation, sir. In infective endocarditis, as you said, the cultures will be sent, and they'll see some growth in that, and the particular antibiotic will be started. But in echocardiography, sometimes I find it difficult where the vegetation, whether it is in mitral valve or aortic valve, because they say something. If it is in mitral valve, the vegetation goes to LV and comes to LA. They say like that, and I don't know whether the vegetation is present in the aortic valve or mitral valve. Second, sir, and third thing is for dissection cases, aortic dissection cases, in suprasternal view, because for example, I'll be going for night duty, and some patients will be having some severe backache, and they'll tell me to see the echo, and I'll be doing suprasternal view, and there will be AR also. Some patients will be having AR, so I find it difficult to differentiate whether the patient is having dissection, because I'll be putting color flow in the suprasternal thing, and there will be AR thing also, but I'll be searching for a flap there. Any flap is there. So these three things I find it difficult in my workplace.
Okay, so let's start with the dissection. So the dissection is predominantly the best part. So I know there is AR. So if you go quite high up a bit, remember when I was saying where we measure the aortic ascending bit a bit. So if you go one rib cage above in your plaques view, long axis view, and then that's where you will have a better view of your ascending aorta. Okay, when you have it there, that's where you put your color there, and then that's the on that's predominantly the best view for you to where you will see any flaps around. Okay, so that's one. Secondly, you you will find it if you go on the aortic arch there. Okay, on the arch, if again put the color there, if you can see the flap there, and if it is a completely dissection of the whole aorta, and then you can see in your abdominal aortic as well. So that's what we say regarding the three places that you will look for it and for your dissection. Is that okay?
Yes, sir.
Okay. And going to your first question was endocarditis, where you will see it. The culture depending. So you need to check what are the culture they tested and they are significant. That can uh, that can prone more to endocarditis. If somebody has strep positive, this is very prone to uh, endocarditis. But if somebody has C. diff, for example, that's not an indication. So you will need to have look at your guideline, the AHA guideline. And but like I said, here we have um, indication triage. Okay, I can't find it here, but I will try to find it and get you guys a copy of that. So we triage for endocarditis. For on the BSc assess guideline, we have it. So what are the things that you're looking for, like Duke score? So always work the Duke score, get the doctor to work that out, and whether the patient is paraxial or not, whether it's culture positive or not. Depending on that score, then you do your and query for endocarditis. Now, if you're scanning your patient looking for endocarditis, it's predominantly on the mitral valve or your aortic valve, depend. Mainly if they had mitral valve or any valve repair or replacement, then they are more prone to these kind of pathologies. And the other thing is if somebody IV drug users type of thing, then the endocarditis type of thing you will see in the right side of the heart, or look, check, always check your IVC uh, and your tricuspid. Okay, I've answered two of your question. What was your second question, I've
Panis, regarding panis,
regarding?
like panis, they say some panis growth is present in the, they say
Oh,
PAN, the panis thing. I think so. I'm right. Panis PANNUS. They say.
okay. So these again, you will, depending on your image quality, how well you see these. But going back to what you said earlier about the thrombus and apical and echinacea, so always try to put the color like you mentioned it, and just mainly with regional motion abnormalities in the apical segment when they have a akinetic wall. That's where you will need to put the color there and see if there's any color flow across or not. But sometimes you can have very type of thrombus, which is just about forming, starting. But then again, assess your patient. Look what's the LV is doing. If it is a severely LV, very high, very akinetic, whole apex, and you take all these into account, then you suggest things. Because I remember a couple of weeks ago, I had one of a patient had LED uh, occluded. We couldn't open it. The whole apical segment was akinetic, EF of 10%, and it was a Friday. I knew this with all these comorbidities, this patient will end up having thrombus. Then on Sunday, I did scan this patient, and there was laminar thrombus already start forming there. So then we didn't have to wait until Monday or Tuesday to start treating this patient, where we could have already starting it before. So again, sometimes there's shadowing, so you just be mindful of that. But when you're not sure, get all the images, zoom on it, bring your depth down, put the color in, pan around a bit so that you can see the trabeculation, and look into your 4, 2, and 3 chamber views. And even when you do your apical short axis, plaques short axis, go down your apical so that you can see at the bottom as well, put the color. At least you've demonstrated, you've tried your best to look at different places, whether, and then it's lets the doctor decide at the end of the day. And if you see something suspicious, do mention it due to the image quality. Always back yourself up and then discuss it with the doctor. Is that okay?
Yes, sir. Thank you. Thank you so much.
No worries. I can't find any other videos, guys, but let's I can't find this video actually, the mass one. But any other question, please? Can we, in terms of reporting and in terms of the image quality, not quality, in terms of image acquisition, so has anyone noticed a pattern in my echoes? Okay, so what I meant is basically my all my study, you can see the same pattern going. So whether whatever pathology from normal to any different pathologies, I've been scanning the same way, and then so that I don't miss anything. Whenever there's pathologies, I go back to the pathologies and report it. So these are the things that I've been doing. And in your practice, get it get that into a habit. Find your own ways, find your own way of scanning, whichever you feel comfortable, and which one you will assess first or not. But then you stick with it. Don't change it. And then that way you will never miss a plane or assessment. And that's always have a checklist in your head, and then you do systematically you go. And some people like to measure as they go along, some tend to measure at the end, but I tend to measure as I go along, and then I build up a report in my head as by the end I finish my scan, I've already made my mind what's wrong with this patient and echo. So which is very important, and then you can give a verbal um, diagnosis as well if you or prognosis. Okay, so these are the things that I will ask you to do. All right, this is your opportunity, guys, to ask questions. So yeah, even question regarding work, not only echo. So yes, if I can have any advice for you, I will. Asha, Pallavi, Srinidhi, any question?
Yes, yes, sir. Actually, I have a doubt.
Yep.
In post mitral valve replacement and aortic valve replacement, like after 10 years of the replacement, they come with the dysfunction, like valve dysfunction and degeneration. Like, how
Yes.
do we differentiate it is dysfunction or degeneration?
Okay. So again, the key thing here, you will look at so most of the aortic valve replacement they will last 10 years or 12 years, same as depending what they use, which tissue they use, whether cow or pig or this. So according to your guideline, you need to look again for MVR, AVR. What are the significant gradient you're looking for? So there is a level of gradient acceptable, but if there is, depending on the make as well, the size, and if the gradient keep going up, and then you will need to put that in context. It's not only about the valve. You need to check for your patient as well. So symptoms, are they symptomatic? Shortness of breath, and are they developing pulmonary hypertension? And you're assessing that. And are they, is the LV function is getting impaired or not? Whether what it was before. So you're taking all these into account to make that diagnosis of the how the valve is impaired or not.
Okay, thank you, sir.
Right.
Sir, I have a doubt. Like,
Yes.
based on the valve type, the normal measurements of the, like for example, um, if the valve is carbomedic, and if that they have done 27 carbomedics, and based on the valve type, whether it is bioprosthetic or prosthetic, the valve measurement normal range will vary, or the same, like, um, for mitral
So
stenosis.
yeah, so again, you need to think about uh that's again go back to your guideline. So for example, like let me just show you uh so in the echo calc, it does give you all these details. So for example, when we go to the valve, and then it will do tell us whether, I don't know if you can see that or not. At the bottom, it will say prosthetic valve measurements. Okay. Now, when you click on that, let's say prosthetic aortic valve, and it will give you a few of the all the type of valves that you have you use. So it's important to know all of these. And then when you click on it, which size, and then it work out which, whether it's mild, whether it's getting worse or not. So personally, you don't need to remember all these numbers and all these type of valve. That's where the apps and the things come into place. So again, depending on the make of it and the size of it and what the gradient is giving you. So then you go by the that assessment.
Thank you, sir.
No worries.
So I have a doubt
Yes.
regarding the BSc exams.
Yeah.
Like, how was the pattern going to be, and are there any classes we need to attend to write the exam?
Okay. So the BSc normally they do workshop, and then there are a few places they do prep courses. So for example, I know, so the term, the way that it is I believe there's 125 question, and you the pass mark between 60-70%, depending how many people pass and fail, that's the way they weight. And the other thing is 25% of the paper will be based on physics. Um, so all the physics aspect, and then the rest would be in all different pathologies, everything that we've been through mostly, and mitral, aortic, and LV, and regional wall, uh, congenital as well. So that would be your theory part one, and the part two bit would be video cases. So you will have lots of video, like for example, today we've just looked at the video cases. So they will give you a video case, and then there will be question based on these video cases. So then you have to answer them that way. So that's how the theory exam is. You have a bit of theory, uh, multiple choice question, and then you will have video cases with multiple choice question based on that. So that will be the exam for the BSc. But regarding prep courses, check on the BSc website. Sometimes they do like workshop and open day and this kind of thing. But I know for a fact there is a, who was this one? So some of the company, so this one, can you read that?
Yes, sir.
The Cardiff, but I can't read backward. Sorry, the Cardiff
The Cardiff
echocardiography course.
echocardiography course, yeah.
Yeah. So I remember when I did my exam in 2019, long time ago. Um, they did so they this is a prep course based on 2 days, okay, and they talk about loads of things, pathologies of everything, and also the physics side and everything. So these are the courses will be very much handy, and I don't know whether they do it virtually or not, but are you, who am I speaking to actually? Okay, so do you live in England?
Yes, sir. I live in England.
Okay,
Yes.
perfect. So
Yeah.
I think the best thing is to check just Google it, the Cardiff echography course, and have a look if they have any space and apply for it. Because personally, I did find it very useful for me, and it was, yeah, it was very useful to attend and get all these pathologies exposures.
Okay, sir. Thank you.
No worries. Any other questions?
Sir, when will be the ECG course? Like another ECG, but I'll be like I'm waiting for the date, sir.
Yeah,
Chidu sir.
ECG actually soon we are conducting actually known no yet actually the dates has been announced. Maybe hopefully by the next month actually we will do one ECG prep courses actually. Yeah. So if you want to attach any kind of additional
Okay.
topics or anything like that, just just send me a message in the WhatsApp so we can do some additional topics as well on that.
Okay. Thank you. Thank you, sir.
All right.
Good stuff. Um,
So
so the Advice I will give you guys is if you're applying for a job in England, which is great, and just make sure how you word your personal statement. And regarding the course you're doing here, some will be very beneficial for you in terms of academia, but you're not going to get lots of practical. That's the issue. And sometimes it's good if you're in this country here, then it's easier to look for job and apply for all these things. And I know it's not cheap, it's very expensive, everything, and you know it's hard. But once you get into the doorstep, then you can um, you you can make your way through. But again, just be honest with in when you apply for job and what you do. Like in term, like now you've seen a minimum database, how much inputs there are into it, and when you do a focus study is completely different. So just in your personal statement, make sure you do say you have lots of exposures on different pathologies. However, is predominantly focus study and they are not tailored or meant to the BSc standard. At least you're saying that you're comparing. Then what, as an employee point of view, they will think about it. They will say, oh, at least they know the difference. You see what I mean? Rather than not knowing. Like for me, if you never knew anything about the minimum data set, you've just applied, you do so many scan a day, and say, wow, that's amazing. I want this stuff to come and work for me. And but then you're not to that standard at all. So these are the things that sometimes people get disappointed, and is depending how you guys word your personal statement, because on paper it will look amazing and great, but in then clinical practice it doesn't meet, you don't meet the criterias. So again, make sure your personal statement is a bit uh, when you're saying something, back it up with something else. So that, and secondly, just as you're training at the moment, just still go and knock on the doors, keep applying for jobs or ETP. Personally, I don't know if you heard of the ETP program, Echo Training Program, but it's predominantly government funded, but it's a UK base, and I don't know whether it's open for international student or worker. But for me, if I was an employer, I was recruiting people, and for that, I will rather employ somebody like you guys who are already scanning. So at least you know how to scan a bit. You will just need a bit of practice how to tailor it to the UK standard and start reporting to this standard, compared to me going to employ somebody who just have a sports science background, never hold a probe in their life, and now we're going to have to start teaching them from scratch. So again, there's a big gap there. So I don't know what the government is thinking about it, but keep applying for these type of role, ETP training program, and then even for the ECHO training program, and then take it from there. Because the problem is the work demand in ECHO in this country is so high. When people try to recruit somebody, they just want them to be able to scan and report. So that's the problem. And so, who you doing the MSc in cardiovascular, not the echo?
No one is doing anything because Pallavi and Srinidhi is doing the MSc cardiology,
Yeah.
and Asha is planning to come to UK for the cardiovascular. No yet reached.
Actually, I'm a little bit confused, Kish sir, because I don't know the difference between cardiovascular and cardiology. But Jiju sir has told me what will be there in the MSc cardiology module, and I don't know which one will, because I am a bit more interested and I'm very much keen in doing echo. Like I like to do echocardiography things, and I wanted to select a job in in echo echo paths only. So I don't know which course to select, because this they say that I have to apply this December, and next September is the intake. So there are I in MSc cardiology is there in Middlesex, and MSc cardiovascular and science. That course is there in Leeds, where the modules I have seen, in that module they have given echocardiography module, but I don't know whether they have clinical thing or not. uh,
I don't think so. Most of the MSc here in England don't have clinical practice. So if it is just a module, then I don't believe you will get it any clinical practice. So the only thing I would suggest is the I think Middlesex do the Echo MSc, which is 1 year. So at least with that, you'll be able to get some core knowledge of Echo, and as well you can start applying for job here or training job or anything like that. And as far as I believe, they do say they provide practice session, but I don't know how true is that. So I can't advise you on that at all. But I can find out because I remember one of my colleague did the course, so I'll be able to find out for you. But it's very difficult in term of so even the MSc in cardiology with your background, what you have back home, and then you bring here, you get this, and then, uh, like I said, many of you have to be retrained to to meet the standard here. So then, if you're lucky enough to get a job interview and getting employed, then it's great. And but if you're here, I would advise you to still apply as a student post as cartographers and non-invasive physiologist type of job, and then take it from there.
so can I apply for MSc cardiology in Middlesex? Is how do you feel, or
So if again, like I said, I don't know the content of that course, but it's purely
okay,
theories. Is purely
okay,
theories. But if you really want to do something, I think at least with the Echo program would be a bit better, because the reason I'm saying that is you will have all the core knowledge of the Echo. You may get some practical there as well, and also you can apply for some job here. So that's where the ETP come into it. So by the end, you never know. By next year, by the time you finish your course, you apply for the ETP program training. They will see you've completed this and you have a bit of experience of holding a probe and getting scanning. And then if you lucky enough, they can employ you. So that's all I can say about it, because I can't
yeah,
talk about the MSc cardiology because I know nothing about that course, and it's purely theory. There's no practical, and whether people they come out of it better, I don't know. So yeah,
okay. Thank you, sir. Thank you so
no
much.
worries.
Yes. All right.
And I just wanted to thank personally, sir, because Kish sir has told me in LinkedIn. I think so. You remember me, sir?
I do.
I texted, yeah, like you only told me about the ETP first time, and still I'm following it. Whether next year will they take me or not? I'm just praying. We'll see.
No, no, but at the end of the day, like I said, I'm here to help and support, and I come from Mauritius, and I start here from scratch 21 years ago. So I do understand, you want to come here, better career, and have a good life, and support your family and all these things. And I really appreciate that. But they say all I can do is give you advice, guys. And recently I went to the conference, and we talk about the
Yeah.
ETP program, STP program in it, and the ETP program, how this is coming up nicely. But again, whether they're going to open it for foreign student, I don't know. The other thing is I'm looking for, because I've been elected, but I haven't been appointed. So I will find out next month whether I do. But the equivalence course, because the degree that you guys do back home is, I don't know how in depth on the theory and the practical you do. As a physiologist is different compared to the way we are trained here. So if we can get you guys to do an equivalence of your degree to turn it into the equivalent to the level of the UK standard, then that'd be great. But I know for a fact that somebody's mentioned about you have to be in this country for at least 3 years to be able to do the equivalence. But this may change, but I don't know what will happen. But this is something I personally want to work, because I can see we can work closely with you guys, because if you already have the fundamental um, theory and practical session, all we need to do a bit of work to get you to the standard here. So this is a bit less work rather than retrain from zero scratch from doing a degree. So yes, so you never know. Watch the space. Things might change in the next few years.
Okay, sir.
Thank you. So do we wrap it up? If you don't have any more question, and but I all mean I'm reachable and get to G, and if you need me any advice I can help with, I will. I'll do my best, and all I can say to you, all the best and good luck with everything, with your application and everything.
Yep. Thank you all.
Thank you, sir.
Do you have
Thank you so much.
Thank you.
okay?
Thank you.
Any
Thank you so much,
No
sir.
worries. Pleasure.
all right.
Pleasure.
Any other questions? Do you have Pallavi, Asha, Srinidhi?
No, sir.
All right. Okay. So yeah. So as per that, we created a WhatsApp group actually. So Kishi's also a member of that. So if you have any kind of queries actually regarding that, any doubts, you can ask in the group as well. And whatever we showed the minimum data sets and all will be posted in that group, so you can refer to that copies. Okay. So after this training, you have some Q sections over there, so you can go through that. So once the complete that, you will get a completion. Okay, so that'll be fine. So thank you everyone for being part of the community. So we are creating a community as well, so like the part of this, so the previous batch students also there in our group actually, so anyone can ask any doubts related to how to come, related to echo your career. Also for Pallavi and Srinidhi, even I can assist you for any kind of other services, like if you want to find any jobs or anything, I can help you with that. I have a team for that actually, so if you need any assistance, let me know. All right. Okay, so yeah, that's all for today. Thank you for I'll post you everything. I'll keep on posting everything. All right. Thank you so much. See you. Bye bye. Have a lovely weekend, guys. Bye
Thank
bye.
you.
Thank you.
Thank
Have a
Thank
lovely
you,
you.
sir.
weekend.
Thank
Bye
you.
bye.
Thank you.
Okay.
Bye,
Bye.
sir.